Welcome. I'm Michelle Cowles, Director of Business Development at Rogers Behavioral Health, and I am your moderator for today's webinar. Joining me today are Dr. Caitlin Pinciotti, Associate Research Psychologist with Rogers Research Center, and Dr. Chad Wetterneck, Clinical Director at Rogers Trauma Recovery Services, to talk about co-occurring OCD and PTSD. Before we get started, I want to give a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available after the program via email sent to you from ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next few days for you to rewatch. Our speakers will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. So if you would like to ask our speakers a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of this webinar. Now I'll turn it over to our presenters.
Thank you, Michelle. Hello, everyone. I'm Caitlin Pinciotti, and I'm here with Dr. Chad Wetterneck. To start, Dr. Wetterneck and I don't have any disclosures to share. Our learning objectives for today are to recognize 3 developmental pathways between comorbid trauma and OCD as they present in the real world, to differentiate 2 classes of similar symptoms of OCD and PTSD, both phenotype and function, and to identify 2 or more treatments and relevant treatment modifications for clients with OCD and trauma or PTSD. So in terms of how we're going to cover this, I'll start off by going through the conceptualization of OCD, PTSD, and trauma. Specifically, we'll talk about the clinical picture, the way that trauma and OCD can intersect, and how PTSD and OCD develop and are maintained. I'm then going to take you through some assessment considerations. We'll talk about some similarities and differences in symptoms of OCD and PTSD. We'll talk about differential diagnosis. And we'll go through some examples of differentially diagnosing between similar symptoms. And then I'll hand it over to Dr. Wetterneck to finish off talking about treatment considerations, including complications of treatment with this population, some recommendations for how to overcome these complications. And then Dr. Wetterneck will provide a brief overview of integrated PE and ERP. So we'll begin by talking about the conceptualization. So I'm going to start by talking first about OCD and PTSD. And we'll start with PTSD. PTSD is really unique because it's one of the only disorders in the DSM-5 that requires that some sort of event happen before the disorder can onset. So for example, somebody can develop major depressive disorder following something like job loss, but we don't need there to actually be some sort of stressful event in order to then diagnose major depression. Someone can also just have depression because of their genetic vulnerability to having depression. So in terms of diagnosing PTSD, we have to first meet this criterion A, that the person must have experienced some sort of traumatic event. And the word trauma can get thrown around sort of colloquially in everyday language, but in the DSM-5, we have a very specific definition of what a trauma is. So a trauma has to be an event that involved actual or threatened death, serious injury, or sexual violence. And there are 4 different ways that we can experience trauma. The trauma can either be directly experienced, like it happened to the person. They can witness the trauma happening to someone else. They can learn that the trauma happened to a close loved one, or they can be exposed to the details of a trauma through their employment, such as 911 telecommunicators. In terms of what a trauma is not stressful life events. So certainly things like divorce, job loss, these can impact folks' mental health, but we wouldn't consider that a criterion A trauma. Trauma is not a death that is not sudden, unexpected, or violent. It is not intrusive thoughts. I put this in there because we hear this sometimes with folks with OCD, that they'll experience their intrusive thoughts. And what they'll describe is that it feels traumatic to them. But again, we would not consider this a criterion A trauma. And trauma is also not witnessing something on TV. So this is something in particularly relevant, for example, the 9/11 terrorist attacks. For those of us who were old enough to remember watching the events on TV, they certainly were very distressing. They may have had an impact on us, but we could not have developed PTSD from just watching the news because we wouldn't consider that a criterion A trauma. So continuing on, then to talk about the diagnostic criteria of PTSD. So we've talked about, first and foremost, the person has to have experienced some sort of criterion A trauma. And I have this little anchor here to indicate that all of these symptoms I have listed here must be anchored to this criterion A trauma. In this graph, the way I've structured this is so the outer ring of the circle is all 20 symptoms of PTSD. And then that inner ring are kind of the names of the symptom clusters. So we've sort of clustered them together with similar symptoms. So we have symptoms of re-experiencing, we have avoidance, we have negative alterations in cognitions and mood, and we have hyperarousal. And Dr. Wetterneck, if you want to just click it once, you might be thinking, there's 20 symptoms. How do we sort of keep this all organized? The way that we diagnose PTSD is this 1-1-2-2 rule. So a person needs to have 1 re-experiencing, 1 avoidance, 2 negative alterations in cognitions and mood, and 2 hyperarousal in order to have a diagnosis of PTSD. And so what this means is someone needs to only have 6 of these 20 symptoms. And so PTSD is very heterogeneous. It can look very different on different people. You can go ahead and advance for me, please. Thank you. OCD is a little bit more simple, right? We have just sort of 2 primary symptoms. We have obsessions, which are recurrent and persistent thoughts, urges, or impulses that are unwanted and that cause anxiety or distress, and that the person attempts to ignore or suppress in some way. And then compulsions, which are these repetitive behaviors or mental acts that the person feels compelled to perform in response to the obsessions. And there may be sort of rules that are applied rigidly. But ultimately, these compulsions are done to either prevent or reduce anxiety or prevent some sort of feared outcome from occurring. And if you want to go ahead and click, the only controversy here with the OCD diagnosis is that as currently written in the DSM-5, it says that someone needs to have either obsessions and or compulsions, right? Which leaves room for there being, cases where someone might only experience obsessions and no compulsions. And some folks have termed this pure O, or a purely obsessional subtype of OCD. So there's some folks in the field that kind of conceptualize a type of OCD as being pure O, although this doesn't really match with clinical experience or with research. There was a paper that actually came out from Rogers data, Dr. Riemann and Leonard and others. They looked at the charting on about 1,100 children, adolescents, and adults. And what they found is that far and away, about 95% of them came into treatment already reporting experiencing compulsions. And for those other 5%, once they really dug into the charts and they kind of read through, they found that ultimately 100% of the sample experienced both obsessions and compulsions. And that in cases of what some have termed pure O, it's more likely that the compulsions are kind of mental rituals that are a little bit harder to detect. So in terms of the diagnostic prevalence of OCD and PTSD, I have a couple stats on here, but I'll explain what this all means. So there's research that shows that 19 to 25% of folks who are diagnosed with OCD also have either current or lifetime PTSD. And this compares to a lifetime PTSD rate of about 7% in the general population. And similarly, about 31 to 41% of folks with OCD also have diagnosed, of PTSD also have diagnosed OCD. And this compares to a lifetime prevalence of OCD around 1 to 2%. So you can see that these are highly comorbid. They're likely to co-occur. What's interesting is that whereas OCD tends to onset a little bit later than other disorders in the DSM-5, it actually has a pretty similar timing of onset with PTSD. So you can see that about 21% of folks experience an onset of OCD and PTSD in the same year. And then they pretty much, for the rest of them, have an equal likelihood of having OCD before their PTSD or vice versa. That's okay, you can advance. Thank you. In terms of just looking at trauma, so not necessarily PTSD, but just folks who have trauma, we know that about half of, or over half of folks with OCD have a trauma history, and this trauma history tends to be pretty extensive. That about, I believe it's 82% of folks who have what we would call treatment-resistant OCD have experienced a trauma history. There's an equal risk of developing OCD following natural and human-made disasters. And this is something that's sort of unique to OCD and panic disorder, that unlike some other conditions, the risk for developing OCD actually increases with cumulative trauma. So the more trauma someone experiences, the greater the likelihood they are to develop OCD. And the same is true of panic, but it's not true for many other conditions. So there's something unique going on there. We've done research, myself and some others, finding that trauma exposure is independently related to obsessive compulsive symptoms. Even after controlling for current post-traumatic stress symptoms or a diagnosis of PTSD or depression. And in particular, there's quite a bit of research on childhood trauma and obsessive compulsive symptoms. That relationship seems to be even stronger for girls, and especially in cases where the trauma occurred before puberty. So why does it matter when the OCD and the PTSD onset relative to each other? There's some research out there that suggests that, the sort of pre-traumatic, meaning that the OCD occurs first and then the PTSD follows, that this is associated with a younger OCD onset, more severe contamination symptoms, and more co-occurrences of comorbid alcohol-related and self-mutilation disorders. However, in cases of post-traumatic OCD, where the PTSD comes first and then the OCD follows, these tend to involve much more severe cases. So obviously it's intuitive, then we would have an older OCD onset because it's coming after the trauma and PTSD. But for folks who have this kind of post-traumatic OCD, we find that there are more severe obsessions and compulsions. There's greater suicidality, so much more risk associated. And more instances of comorbid agoraphobia, impulse control, and panic disorders. In terms of the clinical presentation, obviously we just talked about how the diagnostic onset might impact symptoms, and there's a little bit of research that suggests that a lifetime history of PTSD might make one more likely to experience certain obsessive compulsive symptoms. But more recently, I've conducted some research both with undergraduates who had clinically significant symptoms, as well as a paper with Dr. Wetterneck and Dr. Riemann using our clinical population. And in both cases, I found that when we're looking at both OCD and PTSD symptoms at the same time, so what are the symptoms that they're experiencing right now, not lifetime, when we can control for the overlap that we see in OCD and PTSD symptoms, that there isn't any unique or expected phenotypic presentation. So we were curious, are folks with comorbid OCD and PTSD more likely to have harm obsessions or contamination? And we found that across the board, there wasn't anything that came up as significantly different once you control for the current symptoms. And so basically what this tells us, we already talked about how OCD and PTSD, both on their own, are very heterogeneous. They can look very, very different from person to person. And the same is true of this comorbid presentation. Now, one thing that we found that was interesting is that in both of these papers, the OCD and PTSD group had more severe OCD symptoms compared to an OCD comparison group, but they had similar severity PTSD symptoms compared to a PTSD comparison group. There's also been quite a bit of research looking at, does the trauma type impact the phenotype, the phenotypic presentation of the symptoms? There's quite a bit out there linking sexual trauma and contamination. Folks doing either kind of experimental research in a lab where they're kind of imagining some sort of like sexually assaultive situation happening to them, or for folks who actually have experienced sexual trauma and are asked to recall those memories. In both cases, these contamination symptoms can be evoked, and they can lead to overt washing behavior. So folks might feel kind of an internal sense of like dirtiness or like feeling contaminated in some way, and they might actually then engage in like hand washing or showering. And this is something that actually is even reflected in popular media. It's not uncommon in like a film or a TV show for a rape victim to then go and shower afterwards. So this actually bears out in the research as well. Dr. Wetterneck, oh, sorry, if you could go back. Dr. Wetterneck, myself and Dr. Riemann published a paper earlier this year where we looked at both specific types of trauma as well as the ways in which these traumatic events are experienced. And we looked to see, does this have an impact on OC symptoms? And what I did was basically separate from traumas that are directly experienced, whether it happened to me or I witnessed it happening to someone else, versus indirectly experienced traumas, things that I've learned about happening to other people. And we looked at the difference between those two ways of experiencing trauma and how that might manifest in OCD symptoms. And what's really interesting about what we found is that if you look at the PTSD literature, directly experienced traumas, probably not surprisingly, are more likely to lead to PTSD. We think, well, that's potentially a much more salient event. You actually were there, you were present when it was happening. It makes sense that someone might be a little bit more impacted by that versus hearing about it happening to someone else. That certainly can still lead to PTSD, but it's less likely. But we found the reverse with OCD. We found that indirectly experienced traumas actually had a stronger relationship with symptoms of OCD. And in particular, we kept finding the same thing, that indirectly experienced trauma was associated with symmetry and just right symptoms. And we can continue to talk a little bit more about some of the intersections of these things and why that might be. But we sort of hypothesize that, for folks who have OCD or have the propensity to develop obsessive compulsive symptoms, they tend to experience this like overinflated sense of control. I have to control my thoughts, but I also have to control the things around me and make sure negative outcomes don't occur. And so perhaps for folks who already have this propensity to feel like they need to be in control and that they're responsible for all of these things, learning that something really terrible happened to someone they know might make them sort of overcompensate by engaging in these kind of symmetry rituals that might help them restore a sense of control. And you can advance now. In terms of how we conceptualize the comorbidity, and Dr. Wetterneck is going to touch on this too when he talks about treatment recommendations, we really can talk about conceptualizing this in two different ways. One way is that the OCD and the PTSD have this sort of static comorbidity. They both sort of exist independently on their own, and there isn't really a whole lot of overlap there. And so you can see I have this depicted down as like the two circles. They're sort of just existing independently. And in these cases, it's much easier to address the symptoms sequentially. So which of these two disorders is more primary? Let's treat that first. Once we feel like that's in a better place, then we can address the latter. But what we find a little bit more commonly, this is anecdotal, we don't have a ton of research on this just yet, but it appears that this dynamic comorbidity is pretty common. This is when there's some sort of functional connection or overlap in the symptoms. The trauma potentially could be influencing the theme or the presentation of the symptoms, like I talked about a little bit on the previous slide. And in this case, to the extent that you're able, it's really going to be important to address both of them simultaneously, because what's going to end up happening if you just hone in on one of them is you're probably going to be triggering the other one too. And it's going to be a lot harder for the person to experience those really good treatment gains when multiple things are coming up for them at once and we're only sort of treating one. In terms of how trauma and OCD can intersect theoretically, these are just some examples. So this isn't based in any research that we've done quite yet, but just to sort of get you thinking about what these things can look like. Trauma and OCD can intersect in terms of the theme or the content. So for example, if someone has experienced a sexual trauma, they might have intrusive memories of the sexual trauma that they experienced, or perhaps that someone else experienced. But someone can also have obsessions about sexual trauma, right? I might have obsessions that I'm going to lose control and sexually assault someone else. OCD and trauma can also intersect in terms of function. So perhaps kind of continuing this example of sexual trauma, perhaps following a sexual trauma, someone feels like they need to sort of check the locks in their apartment just to make sure everything is closed up before I go to bed, because I'm fearful that someone's going to break in and I'll be re-victimized again. But that lock checking perhaps now has also taken on more of like an OCD flavor, where maybe I'm checking and checking and checking and checking repeatedly to the point where it's excessive. Maybe I have some sort of specific ritual to it, like I have to check this lock 4 times in this particular way, and I have to check this other lock 6 times, and no, wait, I didn't do this quite right. Now I have to sort of start over with number 1, right? So there can be kind of an overlap in those sorts of things in the function as well. Core fears can also overlap. We talk about with OCD that oftentimes there's a core fear that's underlying the obsessions and compulsions. So, let's say if I have unacceptable thoughts, maybe so I have thoughts about harming children. I might have this core fear that I'm a bad person, and these obsessions I'm having are sort of proof of that, right? But I might also feel like I'm a bad person because I'm sort of blaming myself for the trauma that happened to me. There are also kind of related emotions that can intersect. Things like guilt or shame, people can feel that about both their trauma history as well as their OCD symptoms, especially for those more stigmatized presentations of OCD. And then beliefs. I talked a couple slides ago about this inflated responsibility. It's not uncommon in both OCD and folks who have trauma to feel this kind of inflated sense of responsibility of preventing harm in the future. So again, I'm just going to take you through a couple examples just to make this a little bit more concrete about what these intersections can look like. Some of these are evidence-based, some of them aren't. So this first one here, we've touched on a little bit that, when we have, OC contamination symptoms and sexual trauma, that these can kind of intersect and overlap. The sexual trauma can cause contamination. It can exacerbate contamination that already existed. The person then might feel this kind of internal sense of disgust or emotional contamination that maybe they engage in overt washing behaviors to try to get rid of, but they might still feel this kind of lingering disgust, especially when they experience trauma cues. This example here, this actually, I borrowed this from a patient that I treated who experienced pathological doubt as part of her OCD, but she also had an extensive trauma history that included gaslighting. Now, gaslighting in and of itself wouldn't meet criterion A, but the gaslighting occurred within the context of physical abuse. And so within the context of this physical abuse, she also experienced the psychological abuse where she was always sort of questioning her decisions and, did this actually happen the way that I remembered it? Because I keep getting in trouble and I really thought that this happened, but why would I keep getting in trouble and being abused if it didn't? And so this trauma history that she had was so interwoven with her doubt that she found herself constantly sort of questioning her reality, questioning her judgment of things, and in particular, questioning her memory of everything and specifically of her trauma, which made doing prolonged exposure pretty challenging. Ultimately, she was able to do it. We were able to kind of make a few adjustments to the PE protocol, and she was able to do it and have a lot of success. But this is another way that you can see kind of these intersections here. We talked about this a little bit with the publication that Dr. Wetterneck and I had earlier this year, that these symmetry, just right symptoms coupled with maybe like an unexpected death of a loved one, the person might engage in some of these behaviors to try to feel more in control and kind of overcompensate a little bit. And then lastly, imagine that somebody has scrubulosity or fears about sinning or going to hell, and they've experienced a natural disaster. They might interpret this natural disaster as being something that God intentionally did to them to punish them because they're sinful or unworthy. So again, some of these are kind of anecdotal, some of these are based in some research, but I wanted to make this just a little bit more concrete in terms of thinking about all of the really complicated ways that OCD and trauma can intersect. So now I'm going to talk about how PTSD and OCD develop and are maintained over time. In terms of trauma and risk of PTSD, so depending on what study you're looking at, quite a few people experience trauma over the course of their lifetime, but we see that only between like 6 and 25%, and I think the DSM has it at around 10%, later go on to develop PTSD. So we know that actually most people, even when they experience what we would call like a potentially traumatic event, are actually resilient and don't end up developing PTSD. Certainly there are some risk factors. There are some traumas such as rape that are more likely to cause PTSD. There's a little bit of a greater risk for women over men. And in particular, there are some marginalized communities that are at greater risk, both for experiencing trauma as well as developing PTSD following trauma exposure. So for folks who are gender or sexual minorities, the rates of lifetime trauma in the research have been shown to be as high as like 96 to 98%. For gender minorities in particular, those are folks who are transgender or non-binary. I've seen some studies with very big sample sizes having a trauma rate of 100%. And Indigenous populations as well. In both of these communities, we see a very high risk for sexual trauma, as well as, like I said, developing PTSD following the trauma. And we're going to circle back to that in a bit. So why is it that some folks develop PTSD following trauma and other folks don't? This is something, Dr. Wetterneck, it's going to be a little bit challenging for you. This is very animated. So see if you can try and keep up. I'll try and give you some indications, but there's quite a bit of clicking while I'm talking. So we're going to do the best we can with this. But what I have here is an axis where we have fear on the y-axis, time on the x-axis. And I want to give a little bit of a shout out to the Heinz VA. I did a year-long practicum in their PTSD clinic, and I'm actually borrowing this kind of description of why PTSD develops from my training there. So I wanted to give a little bit of a shout out. If you could undo that for a second. Let's say that I live close enough to work that I can walk to work. And let's say it's a sunny day, I'm feeling good, maybe I've got my earbuds in, I'm walking to work. It's a Monday. I come to an intersection and I look both ways, it's clear, and I go to cross the street. And just as I go to cross the street, this blue car just comes barreling down the street and I have to jump back onto the sidewalk. It has just almost nearly hit me, right? In my body, I'm going to start feeling this fear response, this stress response. My pupils are going to dilate. I'm going to, feel an adrenaline rush. I'm going to maybe get a little bit sweaty. All these sorts of stress responses. I'm probably going to be thinking, oh my gosh, like I could have just died. And maybe I'm also thinking some sort of angry thought about who's this jerk, right? And I'm feeling really anxious and fearful. But let's say in an ideal situation, I sort of take a moment to gather myself and I think like, okay, that was really scary, but I'm safe now. So I'm going to continue along my day and continue walking to work. And you can go ahead and click it now. What I'm going to see is that over the course of the day, that stress response, of course, it's going to spike up when that car almost hit me. But I've had this sort of thought, this kind of corrective experience of like, yes, that was really scary and I'm safe now. And over the course of the day in an ideal situation, my stress response is going to come back down. Tuesday rolls around, you can go ahead and click it. I come upon that same intersection. I remember like, oh gosh, this is where I almost got hit by that car. But I remember like, yeah, but I'm safe. I've walked this way hundreds of times. That's the only time that's ever happened. I continue about my day. My stress response spikes, but not as high, and it comes down more quickly. Wednesday, you can click it, rolls around, same thing. I'm anxious when I get to that spot. My stress response comes down. Thursday, you can click it again, same thing. And Friday, same thing. And this is what happens in an ideal situation, that I've experienced a trauma, but from this sort of cognitive behavioral standpoint, I've made the choice not to avoid, and I've sort of continued along my day. And eventually I'm going to be able to walk that way without giving much of a thought. And you can go ahead and click. Obviously, the ideal situation doesn't always happen. So let's say that same situation happens. It's Monday morning. I'm walking to work. I come to the intersection. That blue car comes barreling down. I jump back and I'm like, whoa, I almost just died. But let's say instead of continuing about my day and going that same way, I think, nope, this intersection is way too scary. You can click. I'm going to turn around. Instead of going this way, you can click again. I'm going to go a different way. And you can click that I have now not had this sort of corrective experience of thinking I'm safe because I've just avoided, right? Tuesday rolls around. I come to that same intersection. You can click it again twice. I decide, nope, it's dangerous. I'm avoiding. I'm going the other way. Wednesday, same thing. Nope, going a different way. Thursday, going a different way. Friday, going a different way. And what happens is you can go ahead and click. This becomes this sort of like muddled mess. This is where the PTSD comes in, right? I haven't had this corrective experience of thinking that I'm safe, and I haven't allowed my body to come down from that stress response. But of course, we know, just like with any form of learning, that this probably isn't going to remain specific to this one particular situation, right? So you can click what initially maybe, what initially maybe was this one particular blue car, now is a different kind of blue car. You can click there. Now maybe it's other kinds of cars and other vehicles. You can go ahead and click again. And what used to be that one particular intersection now is multiple intersections. And now it's even more than just intersections, but it's also roads. And maybe it's also crowds, right? And this is what ends up happening with PTSD, is that as we avoid more and more and more, our life constricts and constricts and constricts. And from sort of more of a cognitive behavioral standpoint, this is how PTSD develops. Go ahead. You did a great job, Dr. Wetterneck. That wasn't too terrible. In thinking about PTSD from a more kind of cognitive perspective, this is something that I've borrowed here. So this is not my original work. The citation is up there. But this is kind of a depiction of what we would call a fear network following a rape. So if you want to go ahead and click here, this seems like a lot, but I'm going to sort of take you through the first thing that Dr. Wetterneck will click. These are the stimulus elements. So these are sort of like the factual components of the rape itself. The rape was perpetrated by a man. He was tall, he was bald, he had a gun. He told me he was going to shoot. It occurred in the suburbs, in my home. I was alone at the time that it occurred. Go ahead and click. These diamonds are the response elements. So this is sort of how I responded to the assault. Perhaps the perpetrator made me say that I loved him. Maybe I froze, I screamed, I developed PTSD symptoms. Go ahead and click on the next one. These are the meaning structures. So this is the meaning that I make of these things. And what we see then are these kind of dotted lines and these solid lines. The solid lines are kind of realistic. So yes, there's a realistic association between rape and dangerous. Yes, the rape and the man were both uncontrollable to me. Yes, I was afraid. But now I've developed these erroneous relationships as well. So now I think my home and the suburbs are dangerous. I think all tall or bald men are dangerous. I think that the fact that I screamed and froze and have now experienced PTSD symptoms means that I'm incompetent, right? So this is sort of just kind of a cognitive depiction of how PTSD can develop. You can go ahead and click. Oh, and actually one thing I wanted to say just about that last slide. In thinking about, we talked about how, folks from marginalized communities, people of color, Indigenous people, LGBTQIA people, the fact that not only do they experience trauma more often, but they're also more likely to develop PTSD. If you think about some of the beliefs that develop as a function of being marginalized in our society and how those might already look a little bit like this, and how trauma can sort of either exacerbate those or feel like they've sort of proven the person right. Like, yes, see, it is really true that these things are dangerous. That can help us understand too why there are greater rates of PTSD in some of those marginalized populations. Now, I won't go through the behavioral kind of model of OCD because it's really quite similar to what I described in PTSD. So I'm just going to review this kind of cognitive model of OCD. If you want to go ahead and click, we're going to start off by experiencing some sort of intrusive thought. This can be certainly informed by personality traits that we have or core beliefs that we have. Go ahead. So I experience an intrusive thought and I make some sort of interpretation about what that intrusive thought means. Now that interpretation, again, is going to be impacted by my personality, my beliefs, the life experiences I've had, and certainly, of course, also by genetic and biological factors. So I might think like, wow, that intrusive thought, like the fact that I had this must mean something about me. I must be a bad person in some way, or I must really want this terrible thing to happen. Otherwise, I wouldn't have thought that. And so this leads to more intrusive thoughts. You can see that bidirectional arrow. And then, of course, negative emotions associated with that, right? Anxiety, distress, shame, guilt, those sorts of things. You can go ahead and click again, which then leads to maladaptive coping, either in the form of just kind of outright avoiding or engaging in rituals or compulsions. And then, of course, this maladaptive coping, go ahead and click, is going to serve to sort of reinforce the interpretation, right? Like, well, I wouldn't be engaging in these compulsions all day long if there wasn't really a need to do it, right? I obviously have to engage in these rituals in order to prevent my intrusive thought from occurring again or some sort of outcome from occurring. And then, of course, on the right side, we have our mood state, which is, of course, constantly going to be impacting every step of the way. If we're already feeling anxious or depressed, we're going to be more likely to kind of go through this cycle. So this sort of gives you an idea of how these things can develop and maintain over time. And similar to PTSD, there also appear to be higher rates of OCD, for example, in the LGBTQIA population. And again, we can kind of think about, as we did on our previous slide, how some of these processes might be impacted by experiences that people are already bringing in with them as a function of being marginalized in our society. So now let's talk about assessment considerations. So as I've sort of alluded to, OCD and PTSD have quite a bit of overlap. And in a few slides, I'm going to take us through lots of more specific examples of what this can look like. But for these first two slides, I wanted to focus on the two kind of biggest overlapping features of OCD and PTSD. The first one being intrusions. So if we look at this kind of middle panel here, the overlap of them, in both OCD and PTSD, we're seeing unwanted, intrusive, recurring thoughts, images, or memories. This leads to feelings of anxiety, distress, shame, guilt. In both cases, perhaps traumatic themes are present. Obviously with PTSD, it has to be a traumatic theme, but folks with OCD can have intrusions about what we would consider criterion A traumatic events, right? Stabbing someone, getting into a car accident. But in OCD, these intrusions are more likely to be present or future focused. Of course, this isn't always the case. Sometimes people develop obsessions over an event that actually occurred, but we see more likely they're sort of these future focused worries. They're often fears that haven't occurred yet. So it's sort of this imagined threat. And they don't have to be anchored to a criterion A trauma. So someone could have obsessions about murdering someone, but they could also have obsessions about their hands being dirty, right? One thing to keep in mind is that when it's OCD, it's likely that someone is going to experience intrusions related to multiple themes. So someone might have like a primary theme that their OCD centers on, but they might also have kind of a smattering of other things, or perhaps they have a history of, right now I'm struggling with, harm thoughts, but I used to struggle with scrubulosity when I was younger. In cases where there's only one theme and it's related to a trauma, that's something to sort of send a red flag up about and kind of look at that a little bit more closely. With PTSD, these intrusions are always going to be past focus related to either the traumatic event or the events kind of associated with it. So perhaps someone has intrusive thoughts about the car accident, but they also have intrusive thoughts about, being at the hospital afterwards. And in PTSD, these intrusions have to focus on a criterion A trauma that the person actually experienced. And avoidance. Certainly when folks are experiencing really upsetting, distressing, intrusive thoughts like we've been talking about, it makes sense that a lot of people might have the tendency to want to avoid that, right? Who wouldn't? In the middle here, in terms of how OCD and PTSD overlap with avoidance, this can involve explicitly avoiding things like I'm not going to playgrounds because that triggers my obsessions, or I'm not going to go to that part of town because that's where I was mugged. Things like safety behaviors. These are more kind of overt behaviors that are engaged in either OCD rituals or PTSD safety behaviors that are done either in response to or to prevent intrusions, to neutralize unwanted thoughts or feelings. And what we see is that the more somebody uses these avoidance behaviors, they tend to grow over time, right? And someone might develop reliance on them, these kind of have to beliefs, like I have to do this, I have to do that. And of course, then that makes a person feel like they have less self-efficacy. They don't really believe in themselves to be able to adequately cope with the trigger. And of course, then this is going to interfere with having these corrective experiences. Like when I decided that I was going to turn around and go the long way to work, rather than allowing myself the corrective experience that even though I almost got hit by that car that one time, that intersection might not be inherently dangerous. In OCD, the rituals are typically done to prevent some sort of imagined threat. They can have kind of a rigidity to them, some sort of pattern or a set of rules that must be followed. They're oftentimes characterized by self-doubt or feeling like this isn't just right, I need to sort of redo this. They're repetitive. They can involve magical thinking. And then typically the avoidances of situations that trigger obsessions or compulsions. Whereas in PTSD, safety behaviors are typically done to prevent re-victimization or to neutralize some sort of current perceived threat. And they're sort of completed until the next threat comes up. So they can be perfectionistic in some ways, but it's usually only insofar as they serve to minimize additional threats. And then there's more kind of a concrete ending to them. And avoidance can be of both trauma triggers as well as the trauma memory or feelings associated with the trauma. So things to think about when you're assessing for OCD and PTSD. First and foremost, are the OCD or are the symptoms related to trauma and how much? Now, we didn't go into a lot of specific PTSD symptoms, but for those of you who are more familiar with the diagnosis, the cluster B and C and some of the cluster D symptoms have more of a content to them, right? They're nightmares about the trauma, they're intrusive memories of the trauma, avoidance of trauma triggers, blaming yourself for the trauma. There's clearly like a content association. But then some of the remaining symptoms, the hyperarousal and a few of the negative alterations in cognitions and mood, they don't have like a concrete trauma association. They're things like difficulty concentrating, difficulty with sleep, feeling like an exaggerated startle response, hypervigilance, generally just feeling a lot of negative emotions or difficulty experiencing positive emotions. So in these cases where there isn't a clear content connection, we would ask, did these symptoms start or get worse after trauma? And if the symptoms always existed and they weren't impacted by the trauma, that's going to give you an indication that it's likely OCD versus PTSD. Consider the intersection with content, so the obsessional content and intrusive thought content, as well as intersection with function, related to safety behaviors and compulsions. Consider what is sort of the root of the person's functional impairment and distress. So if they're experiencing both, is there one that feels like it's driving more of their functional impairment? Like, yes, they have both OCD and PTSD, but they're stuck in the bathroom doing OCD rituals for 8 hours, right? That's where most of their functional impairment is coming in. And then onset, we talked about that too. When did the OCD onset relative to the trauma? When did these things onset relative to PTSD, and so on and so forth? So this is just sort of a diagram just to get you thinking about what this can kind of look like if someone is reporting that they're having disturbing intrusive thoughts. So we can click from here and ask, are these intrusive thoughts related to a criterion A trauma? Let's say, yes, they are related. Or no, they're not. If they're not, then maybe it's OCD, maybe not, right? We need to look at that more. But if they are related to a criterion A trauma, then we can ask, well, is this a trauma that the person actually experienced, right? Did they either directly experience it, did they witness, or did they learn about this criterion A trauma? Or is it something that they're just more sort of fearful of without having that actual experience, right? So if no, again, kind of maybe OCD, let's continue to piece that apart. But let's say, yep, they're related to the trauma. It is a trauma they've actually experienced in some capacity. Are these intrusive thoughts occurring in tandem with other symptoms of PTSD? So remember we talked about the 1-1-2-2 rule. Someone needs to have symptoms in all 4 of those clusters in order to have a diagnosis of PTSD. So are they experiencing avoidance, negative alterations in cognitions and mood, and hyperarousal symptoms that, again, are anchored to that criterion A trauma? If not, we would say maybe it's OCD, maybe it's subclinical PTSD, but if so, we say, okay, are these symptoms clinically significant and have been occurring for greater than a month? And if all things are yes, then we would say, this sounds like this is PTSD, versus if not, we would say maybe this is subthreshold PTSD. So this just gives you a way to kind of think about some questions when someone is reporting these intrusive thoughts, how to sort of break this down to differentially diagnose. So the last section, I'm going to go through some specifics. There's a lot of content on these slides. So I might go through them a little bit quickly just to make sure that Dr. Wetterneck has enough time to talk about treatment considerations. You will have access to this information, and certainly I'm happy to answer any specific questions that you might have. But this is a chart that I created for a review paper on co-occurring OCD and PTSD, and it's going to be published sometime around May of next year in a special issue on OCD and co-occurring disorders. So if this is something that's interesting to you, you can also access it in that paper when it's published next year. But we already kind of talked about how to differentiate obsessions and intrusive memories. So I'm going to skip past that one down to the second one, that in both OCD and PTSD, we might see this kind of like psychological and physical manifestation of anxiety or distress. And one way that we can kind of differentiate these things, or some considerations we can make, is that in OCD, this anxiety or distress is going to be triggered by OCD cues, versus in PTSD, that will be triggered by trauma cues. Again, I'm going to skip past the avoidance because we talked about that as well. And I'm going to skip down to pathological doubt. This is something that not every single person who experiences OCD, this might not be relevant for them, but for some folks, we do see a lot of that doubting kind of underlying their rituals. And in PTSD, some folks might have amnesia. They might have kind of gaps in their memory. These gaps can be, kind of moments within the trauma itself. Like, yeah, I remember I was walking down the street and someone approached me, and then I really don't have any recollection until, 20 minutes later when X, Y, and Z happened. But people can also have much larger gaps. Like some folks who've experienced like chronic childhood trauma might say, like, there are like entire years of my childhood that I just really cannot remember. So it's not uncommon for folks to experience this amnesia within the context of trauma. But of course, this can muddle things a little bit when someone has OCD and PTSD, and it's like, well, wait, does the person actually have gaps in their memory related to trauma? Or are they sort of doubting themselves? And that's where this is coming from. So some things to think about. In OCD, these reported gaps in memory might evoke kind of more anxiety. And they're more likely to be a product of self-doubt. So it's usually more of like a doubt of whether or not this thing occurred. Whereas in PTSD, it's less likely that it's doubt that something occurred and more likely that there's actually a gap in the memory. And some folks will say, like, they more so feel confused, or some folks will even feel curious, like, I just want to know what happened during that time. Obviously, for some folks, it can be anxiety or distress provoking as well. But in PTSD, this amnesia can be a product of emotional avoidance, either intentional or unintentional, the brain kind of protecting the person from fully remembering what happened to them. We've talked a little bit about like core fears and negative beliefs that someone can have. The sort of I'm a bad person or I'm a damaged person can be implicated in both OCD and PTSD. These core fears in OCD typically provoke anxiety, and they're related to the obsessional content, whereas in PTSD, it can also provoke additional emotions like guilt, shame, hopelessness, and there's usually more of a clear connection to the traumatic event. And like we talked about, these symptoms must have started or gotten worse after the trauma in order to be counted as PTSD. This inflated sense of responsibility can overlap in PTSD with kind of distorted beliefs about the cause or the consequences of the event, either blaming oneself or blaming others. In OCD, this can include kind of magical associations, right? Like if I don't count to 10 4 times exactly the right way, my mom is going to die. Versus, having, again, kind of a clear and rational connection to this was the trauma that happened. This is why I think that I or someone else is responsible for it. Even if we think it might be excessive, there's usually a clear kind of logical connection there. You might see in OCD and PTSD that the person isn't engaging in their previously enjoyed activities as much. But in OCD, it's more likely to be due to avoidance of OCD triggers, or perhaps the person is stuck engaging in compulsion. So yes, I do want to go out and hang out with my friends, but I'm stuck cleaning all day. Whereas in PTSD, there's actually kind of this like internal sense of like a diminished interest. Like I truly don't feel as interested in this activity as I used to. Again, another thing that you might see is this kind of social isolation in both OCD and PTSD, but similar to the avoidance of previously enjoyed activities. In OCD, this might be due to avoidance of OCD triggers, maybe shame about someone's symptoms, or again, just sort of getting caught up engaging in their rituals. Whereas in PTSD, you'll often hear folks saying like, I'll be around other people and I just feel like totally disconnected from them. There's like something internal. I just feel like I can't really connect with people very well. And then this is the last slide, and then I'll turn it over to Dr. Wetterneck. Occasionally in OCD, you'll see folks engaging in what we will call testing rituals. So the example I gave here is from a real case. The person was afraid that they were going to contract a sexually transmitted infection. And so what they would do is intentionally engage in unprotected sex to sort of test, like, am I going to get this or not? They just felt so intolerant of the uncertainty about whether or not they were going to get it that they were sort of pushing themselves to obtain sort of the feared consequence, so that they wouldn't have that kind of uncertainty anymore. Whereas in PTSD, sometimes folks might engage in reckless or self-destructive behaviors. I've put here kind of similarly, engaging in risky sex following a sexual assault. So in these cases, we can differentiate that. In OCD, these testing rituals, the function is to disprove or to obtain some sort of control or certainty over the feared consequence. Whereas in PTSD, there could be several reasons. For some folks, they might engage in reckless behavior to sort of intentionally invoke this kind of adrenaline rush. I've worked with veterans, for example, who will speed down the highway because it gives them this sort of adrenaline rush. Someone might engage in self-destructive behaviors to punish themselves, or perhaps to reenact aspects of their trauma with a greater sense of control and empowerment. So if someone is sexually assaulted, they might intentionally start engaging in a lot of sex to feel like, well, see, now I'm in control of what happens and I'm sort of taking the control back. Certainly in OCD and PTSD, we can see this kind of hypervigilance or this alertness. I gave an example for OCD of, if you feel like there's a contaminant, you might be sort of really carefully tracking like all the people that touch this contaminant, all the surfaces that touch the contaminant. And so in this case, this sort of alertness is specific to OCD cues, whereas in PTSD, it can be specific to trauma cues. It can also be just sort of this like broader need for like, I need to scan for threat or danger. I need to sort of, what we'll see sometimes folks will like, if I go to a restaurant, I'm going to intentionally pick the table and the chair that's in the corner of the room so I can scan and see everything around me and no one can sort of come up behind me. So it can be sort of more of like a broader need to scan for threat as opposed to being specific to an OCD cue. Problems with concentration. In OCD, this could be due to somebody, experiencing their obsessions or engaging in a lot of mental rituals. Whereas in PTSD, this could be trauma-related intrusive thoughts or just generally maybe a feeling of like a brain fog. Sometimes people will describe. And then lastly, sleep disturbance. Certainly we see sleep disturbance is really common in both OCD and PTSD. When someone experiences sleep disturbance within the context of OCD, it could be related to this kind of hyperarousal, their obsessions, maybe their engagement in compulsions that are, again, specific to OCD triggers. Whereas in PTSD, it can be related to hyperarousal, trauma-related intrusive thoughts or safety behaviors that are specific to those triggers. Or sometimes you'll see folks who have sleep problems because they have such terrible nightmares that they then have kind of anxiety about falling asleep and experiencing nightmares. And so why does it matter? I've heard people say this, like, well, if the treatment is similar, which Dr. Wetterneck has described, like, why does it actually matter to sort of piece these apart? There are these kind of nuances in the way we treat symptoms. It's different. If when I'm talking with someone, they ask me a question that feels like reassurance seeking, if it's reassurance seeking related to their trauma or PTSD, I'm going to be more likely to answer that question than I am if somebody has OCD, where there's more of an emphasis on kind of tolerating uncertainty, versus PTSD, where we're trying to help people relearn safety cues, what's safe and what's not safe. We want to understand the function of the symptom. And then certainly depending on if the symptom is coming from more of an OCD place or a PTSD place, that can impact the exposure content as well. And so with that, I want to thank Dr. Wetterneck for doing such a fabulous job clicking through the slides. I know I had some animation, so you did a great job with that. And I am going to pass it on to you.
Thank you, Dr. Pinciotti. It's always a pleasure to work with you, and now I get to do my first talk with you and I co-presenting. So honored to be able to do that, and I've enjoyed our time working together. And now I can replace the comment of I didn't do too terrible with I actually did a decent or better job. So I'm going to talk a little bit about treatment complications. But I do want to say one more thing. I want to do a couple of acknowledgements. One, that most of the stuff that you're going to see, including the way the slides are presented, actually come from Dr. Pinciotti's excellent talk from the International Obsessive Compulsive Disorder Foundation's 2020 online conference, looking at these very same issues of overlap between OCD and PTSD. And I'm grateful to her for allowing me to utilize those slides. As I said, they look smarter and just more visually appealing than what I had come up with. So thank you for letting me use them. And I just want to acknowledge too that I have no other disclaimers except I feel like after going after you, Dr. Pinciotti, it reminds me of being out at a karaoke night and hoping the person that goes up right before your song isn't that good so that your song will sound better. But now the pressure's on me. So I'm going to use the remaining time before question and answers to talk about treatment complications and what we do in treatment itself. So just briefly, I want to mention that we know from case studies, case series, and a longitudinal study, and from our own data, you've already heard this from Dr. Pinciotti, that we might see higher levels of symptom severity when we're looking at comorbid presentations of OCD and PTSD. On this slide here, you see data from the Brown longitudinal study. That was a study that followed patients for over 7 years, and you'll see two different lines here, the yellow line being symptom severity of those with just OCD, and then the gray line being symptom severity for those with OCD and PTSD. And over the years, you see in general higher symptom severity, but you see a lot of other things that are really relevant to treatment as well, including poorer treatment response, higher dropouts, and more severe OCD symptomatology. Now, we don't have any randomized clinical trials that have actually taken a group of people and compared OCD and PTSD in the comorbid presentation. We can dare to dream, and maybe we'll be running a study like that someday. But it does seem as though all of the other data indicates that there's a lot of nuances and maybe structural issues with treatment that we need to address in order to make adjustments. So we have co-occurring PTSD and OCD treatment, and a lot of potential impact here, including that, as Dr. Pinciotti pointed out, many of the symptoms overlap. There could be a desire on behalf of the patient or the therapist or treating professional themselves to want to know, what is this from? And I'll talk a little bit about that on whether we need to know, is this more OCD, is it more PTSD, and how much time do we actually spend on that? We also know that there's some core fears that can overlap as well. A lot of what we look at across anxiety disorders in general is a threat to oneself. The type of threat might be different, whether it's social phobia, OCD, PTSD, or any of the other anxiety conditions. But we're going to see some overlap there. And those core fears might fuel one or both conditions. This general phenomenon of seeing if we treat only one of the conditions first, then we might see the other symptoms increase. So if we were to focus mainly on OCD treatment in folks that have clinically severe levels of both disorders, you're going to hear me talk about the dosing of what we want to do has to be divided up and geared to treat both conditions at the same time. And that might be 50-50, or it might be some other percentage that we break that up into. And then we know that some PTSD treatments are going to interfere with treatment as well. So it's really interesting. We can look at lots of anecdotal information we have at our own hospital system and see that when we have people that call in and say they want to work on their PTSD, if we don't get them in within a couple of weeks, they might not return our calls when we say, hey, we're just following up on you and updating you on the wait lists. When we do that with people that have primarily PTSD, we have folks calling us sometimes multiple times per day, every day, until they actually get in. So there's a little bit more of an approach in general to move toward therapy, whereas avoidance of people, interactions, and emotions seems to be pretty strong with our folks that have PTSD or comorbid PTSD and OCD. I'm going to make sure I just cover the main points in these slides, just in interest of time. So if I pass a couple of things, that's why. In fact, I'm going to skip this whole slide, but you will notice a reference for this at the end that talks about some of the research we've done. It's just a little too specific, though, for the purposes of our conversation here. I want to really get into our treatment recommendations. So if you work with either OCD or PTSD, you might already be aware of what are the main evidence-based treatments. And when I say main, I just mean the ones that have had enough research to say the scientific community should support the use of this to treat either one of these two conditions. Now in OCD, it's a little bit more clear that there's really one gold standard treatment based on the amount of clinical trials, head-to-head trials, and kind of a lack of trials in other areas. Exposure and ritual prevention is definitely what is recommended by and large. And of course, you can try other things, but the recommendation is to start with exposure and ritual prevention. And then in PTSD, this is an area I work in as well, and I see a lot more heterogeneity of the treatment approaches, and then also a lot of differences on the amount of research support for them. So I like to call this list of recommendations under PTSD what I would refer my family or friends to if I thought they had PTSD. I would want to send them to someone that was experienced in one of these three treatment approaches, either prolonged exposure, cognitive processing therapy, or eye movement desensitization and reprocessing. And we use at Rogers Behavioral Health a combined exposure approach where we're using elements of ERP and prolonged exposure to try to treat people with a comorbid presentation. I want to give you a little bit of reason why we use more of an exposure-based treatment. One, I already mentioned that EXRP is the gold standard for our OCD. And while there are a few treatments you could choose from PTSD, we chose prolonged exposure for a number of reasons. One is it literally has more studies, more people in studies, and the APA recently did an overview. In fact, they're working through all the main disorders in the DSM, and they're not trying to say which treatment is better than another treatment, but they are trying to say we're establishing different levels on how much more support we think we need to explore whether or not a treatment should be recommended for use for a particular disorder. Well, luckily for us, they actually started with post-traumatic stress disorder and published their findings around 3 years ago. And what they found is that they noted that 2 treatments based on the scientific rigor of their studies and amount of data and what their data said, they said that we probably don't need any more RCTs basically saying, does CPT or PE work? We're pretty certain of the fact that they're very helpful for PTSD symptoms. And then EMDR also has a number of studies on it. And the amount of studies and the other factors that play a role in this said, we probably don't need too much more research, but if there was more, that might help round out and make us feel better and just saying, yes, we can use this as a treatment as well. One thing that was really interesting is that when the APA published this report, a lot of folks said, hey, we really think other treatments need to be looked at. And I wholeheartedly agree with this. In fact, I think the more we can interject a little bit of science into what we're doing, more randomized clinical trials, or at least more study and processes of change, the more the merrier. But some of the points that were brought up that kind of criticized this APA report included things like, well, we need to really look at who is being treated in these treatment trials. We need to look at things like gender, marginalized populations, what type of traumas occurred. And so I really liked that there was this community of folks that spoke up and said, let's think even broader than just RCTs. And so my research lab actually has an article coming out later this year that looked at all of the same studies the APA looked at. And we managed to collect data from people that didn't publish any amount of diversity in terms of who was actually part of their research studies. And what we ended up finding, and we specifically looked only at race and ethnicity as reported in studies and through emailing the folks that hadn't reported it in their original published work, what we found is that there was a difference in the 3 main therapies for PTSD. We found some similarities in that folks that identified as Asian or Native American and other types of BIPOC groups, besides those that identified as Black, they were typically underrepresented regardless of what treatment modality was being tested. But we did find a large difference in those folks that identified as Black. And in that, we found that prolonged exposure had the most inclusive rates of including people that were Black at close to 30% of the treatment trial, which is more than double what the census data says in terms of the amount of people that identify as Black in the US. And then in contrast, CPT had a lower rate. And then for EMDR, they had 0.0 people that identified as Black in the treatment trials. So there's more work to do in all of these areas, but I really think we need to keep investigating that. The other thing is that there's some shared principles of exposure work here. Now, treatment really is different in the exposure principles you use, and hopefully I'll get to talk about that slide a little bit here. But there's enough of a commonality here that if you can train your therapists how to recognize which things might be more OCD, which things might be more PTSD, and what's in the middle and how to deal with that stuff, the shared principles really helps with any experience level of clinician, and also helps, I think, the patients not have to learn a separate treatment modality. So when we look at ERP and prolonged exposure, the two exposure-based treatments, we see a lot of similarities. They're exposure-based. We expect there to be some amount of habituation, but we also look at this as a corrective experience and, the idea that they're going to build some self-efficacy. We might talk about that a little bit more though in PE than we do in ERP, because we don't want to accidentally give reassurance to our folks with OCD or for OCD symptoms. We're really targeting avoidance. We're doing a lot of in vivo exposures, and we focus really on reducing rituals and safety behaviors. You're going to see some differences, though, on how we would address that if it was only OCD-related symptoms versus only PTSD symptoms when we talk about exposure work. So while we think the OCD symptoms are going to be maintained through avoidance and other rituals, in the emotional processing theory, we look at prolonged exposure as useful for helping change the maintenance of that's caused by avoidance, but also through the beliefs that people develop about the trauma being their fault, that they can't trust anyone and they can't trust themselves, and that this isn't likely to repeat itself as well. You might see some imaginal exposure work in ERP. You are definitely needing imaginal exposure work in PE, and the way you conduct that might be vastly different than what you do for OCD symptoms and OCD treatment in general. Whereas you can give more support and say more things that let them know they're actually doing well in an imaginal exposure. Whereas in OCD, you might not comment at all on that. You might just encourage them to keep going. And if they avoid, you might actually start talking about some of the difficult things that they should be thinking about. We tend to gradually reduce safety behaviors when we're working with PTSD symptoms or in PTSD in general. Whereas in exposure and ritual prevention, we're going to ask to see whether or not they can engage in full ritual prevention early on. That's not always possible, especially at our level of care, but we always want to ask for that first, knowing that they might feel unsafe, but with our folks that have PTSD, they've already experienced something that they know could have been life-threatening to them. So we are a little more hesitant to engage and say, you can't do any safety behaviors at all. I've mentioned a few of these other things already, but I do want to point out that, especially for folks that were trained in ERP for OCD first, a lot of the things that you might do to maintain your therapeutic alliance with people in prolonged exposure might seem like it's reassurance giving. And I want to let you know that if you were trained in ERP first, you're going to get that sensation of, I feel like telling them that they're doing a good job. I feel like actually, saying positives about them during or after their exposure work might function as reassurance giving. But we have to try to distinguish, and this is when we look at differences in symptoms, what types of symptoms are actually impacted by compulsive doubt versus which ones are not. And what we see is a fair amount of our more post-traumatic stress disorder symptoms do not have a compulsive doubt component about them. In fact, if someone were to compulsively doubt something, the most frequent presentation I see is whether or not people remember the event correctly. Did the event that's traumatic even happen? Was it really as bad as what I thought it was? Because if not, maybe I'm augmenting how bad it is, and I'm gonna get someone in trouble for it. Now, those are OCD symptoms that intertwine with PTSD, and so we end up not giving reassurance to those symptoms. But when someone's doing imaginal exposure work and they need to be grounded and stable enough to actually stay in that imaginal exposure, we are going to say things that feel like it's reassurance giving, even though that's not the function of it. I already mentioned this, that there's lots of overlap in what we do in our exposure work. The psychoeducation is fairly similar, but we do need to emphasize to our patients that there are some unique differences. I've already mentioned some of those, like we might give supportive statements in one to address some certain types of PTSD symptoms, but not so much when we think that the symptoms are more related to an OCD type presentation, or when they're in kind of the range where we're not sure, there's some OCD here, there's some PTSD here. And, if you're working with folks with OCD quite a bit, sometimes you'll get those questions like, well, aren't you supposed to be reinforcing me for doing my in vivo exposures for my OCD? That would be nice to hear. And, we have to tell them that if they do have any sort of compulsive doubt, that they have to sit with that uncertainty to not know whether they're doing a good job or not in that area, and that we will give them things that sound like praise and reinforcement for things that we know are more PTSD related. We do want to try to look at exposure to different treatment barriers as well. I'm going to talk about that on a future slide. I've already talked a little bit about the differential diagnosis in the moment, to reassure or not assure. And I just encourage you all to have an open conversation with someone. And I will sit down with a patient and I might map out which of these symptoms that you're presenting with do you think are more OCD related? Which do you think are more PTSD related? Now, this can vary a lot on where they're willing to put things based on how much compulsive doubting they have. But I do find that people are willing to help categorize those things. And the more they leave in the overlapping, they might be some of both. I'm going to tell them that I might pose them a question in the moment. Do you think you're asking for reassurance in this moment? Do you think that this is something more related to OCD? Like, if you were to imagine me saying you're doing a good job, would you feel more relieved instantly in the moment? And if so, it's a pretty good sign it's OCD. So we're gonna ask those questions in the moment, but actually give them that framework ahead of time. Now, when we look at dosing, when we look at dosing for exposure-based treatments, if people are coming in with severe levels of both, I'm going to start with saying we need to do about 50% of our treatment dedicated more to OCD work and exposures, and the other 50% is going to be in vivo and imaginal exposures for your PTSD. You might alter that as needed. If you were to decide to only do more of the let's treat one approach at a time, you are likely to find that if you get a foothold on the OCD area, well, as you're trying to get that foothold, you might be activating a lot of trauma responses. So keep in mind, every time you're trying to have someone experience some anxiety so they can habituate to it or achieve extinction, you're really giving them that sense of being unsafe that could be related to their trauma experience. And I've had plenty of patients say, I don't even want to do exposure work. I can't deal with this at the moment. I can't even start doing very low level exposures because it's activating my trauma response. Now, they're not always aware of that. We have to be aware of that for them. That's why we do more of a 50-50 approach. If things aren't working well with exposure therapy in general, I mean, we always want to go back to the basics. Have you communicated? Have you understood, first of all, what are their concerns? And are there concerns that might be related to one or more of the diagnoses they have? I doubt this treatment works, in which case we're dealing with some uncertainty, and we almost have to use that as an exposure that's more OCD based on getting them to move forward, and not re-explaining all of the aspects of treatment over and over again. But we really want to do a good job of validating any concerns that are there. And before we then go over, how much do we need to review the treatment rationale? Now, I want to make sure we get to questions and answers. So I'm going to go through the last couple of slides, just pick out a couple of key points that I want you to be aware of. The other is that there might be some overlap that you can do with either ERP and cognitive processing therapy, and potentially even overlap between more of a cognitive approach to treating OCD and cognitive processing therapy. But I will say that there's just less research on cognitive therapy for OCD, even though the initial studies seem quite promising. So I want you just to orient you to this slide and looking at treatment similarities, because a lot of this actually overlaps with what you saw for the ERP and prolonged exposure portions. And if I were to pick out a couple of main differences here, we might be looking at things that you find in kind of like Jeffrey Young's original conceptualization of what maintains kind of like chronic depression, kind of this early maladaptive schemas and core fears, and how these core fears might influence both the PTSD portions of their presentation and some of the OCD portions of their presentation. In CBT, you're not going to do very much exposure work, although I will say that behavioral experiments do seem as though they can be like exposure work, and talking with people and asking them to share any part of their trauma narrative is really exposure work, even if it isn't the repetitive way in which we do it in prolonged exposure. There's a lot of things that you would add in terms of what you'd want to do for cognitive processing therapy. And I was referencing those early maladaptive schemas that Jeffrey Young came up with. And those things really align quite well with some of the basic tenets and areas you'd focus on for CPT, including identifying whether or not people have kind of stuck points in areas of trust, safety, power and control, intimacy, or how they feel about themselves. There's a much more of an emphasis on trying to do some written expression and therapist-guided Socratic questioning, but also worksheets that you can use to augment what they do and work on their own. I think these things can be quite nice because if they can make it through these types of strategies, then in a sense, they're able to do some sort of self-validation that they made it through. And if they see changes in their, how strongly their trauma beliefs may have changed, their emotions have been reduced as a result of this work, that's really a nice internalized effect that they have. And it shows them that they have skills they can carry forward with them and be their own kind of like CBT therapist. I really want to be able to give you more resources out there on the comorbid presentation, but there really just isn't a lot out there. So one thing that I want to show you is that I believe on the previous slide, I may not have mentioned it, but there was a hyperlink that shows you trainings that you can do at UPenn by Edna Foe and some of her colleagues, and you can learn about prolonged exposure there. Similarly, there's a hyperlink here that is going to show you resources for cognitive processing therapy for PTSD. And you don't have to only go to like the motherships where the inventors of the treatments go. There are many people that are identified as trainers in both of those areas. And if you use your Google powers, you will find them. So I do want to make sure we have around 10 minutes or more for questions and answers. So I'm going to let Dr. Pinciotti come back on and Michelle Cals come on to lead the Q&A.
Thank you, Dr. Wetterneck, Dr. Pinciotti. Now it's time to answer your questions. If you have a question, please use the Q&A button, not the chat feature on the Zoom taskbar. We're short on time, so we probably won't get to all of the questions. If you don't get an answer to your question, please send me an email message afterwards and I'll follow up with you. It looks like the first question is, to what extent are individuals open to the idea they may be dealing with both OCD and PTSD, particularly when they have only been seeking treatment for one or the other?
I'm happy to start us off, and Dr. Wetterneck, if you want to add to it, that would be fine. This is a great question, and actually I just saw on the chat pop up from Nathaniel Van Kirk. I'm glad that you were able to join us. This is actually something that that he and I have talked quite a bit about too. A lot of times what you see when folks have OCD and PTSD is that they feel different than their peers. So, here at Rogers, we have our kind of specialized treatment programs. Folks might be here in the PTSD program with Dr. Wetterneck, or they might be in the OCD program, but they're noticing that their symptoms are just a little bit different. And so in my experience, a lot of folks actually feel very validated by kind of developing an understanding of like, this is where these symptoms and these behaviors are coming up for me. And this is why I feel a little bit different than some of my peers who only have OCD or only have PTSD. Whenever I do a PTSD assessment, what I'll often do is kind of talk through, based on the answers you gave me on the CAPS, the clinician administered PTSD scale, your responses are consistent with the diagnosis of PTSD. Like, what do you think about that? Do you feel like that matches on with what you're thinking? What are your thoughts about this diagnosis? Some people will say like, yep, it's nice to have a name for this. Other people might feel like having this diagnosis might feel a little bit stigmatized. So I think in either case, it's important to just talk about the label and what does it mean for folks. And something that I'll often fall back on is, whether we call it PTSD or some random nonsense term, it's the same, right? We're just coming up with some label that describes the experiences you're already having. When you walked in the office today before you had this diagnosis, you're not any better or worse off than when I told you that you have PTSD. We're just kind of thinking of, how can we conceptualize this? What sort of common language can we use to describe this?
And I'll just add two brief things from my own experience. And that when we see folks that come to Rogers, and if you don't know much about what we do, we don't see people once a week. We only do IOPs, partials, residential, and some inpatient work. Most of the folks have gone through treatment before, so they seem to be fairly receptive. However, in outpatient treatment, I think this varies based on how much treatment have they sought out already, and has it worked or not worked up to this point? Because I see the general trend especially going back to that admissions example I gave, is folks want to avoid talking about post-traumatic stress disorder. So maybe it's not always as well received and many people come in because they want to talk about sleep problems, interpersonal difficulties, depression, substance use, or maybe their OCD, and I'd rather not talk about the PTSD. So it can vary quite a bit depending on what setting you're in.
Thank you. The next question is, along with that, among individuals with both conditions, is there one they are more likely to recognize or seek treatment for?
I don't know that we have the research to say what do they recognize, but I will go back to what I said, that I've had people come in to say they have one condition, like one of the aforementioned comorbidities, and when I ask basic questions about, have you had trauma? No. Well, wait, have you had emotional trauma? No. Physical trauma? No. Sexual trauma? No. And then I'll actually give them examples of that, and no. And then, 8 to 10 sessions in, exposure work or something else isn't working quite well. And you find out, yeah, they have PTSD as well. And we know, the only other thing I know from the literature is that there's a lot of misdiagnosis with a fair amount of OCD presentations, especially the ones that aren't as common. So in terms of what the patients recognize, that might be up to their Googling powers and willingness to reach out to professionals and talk about it.
Thank you. That's all the time we do have for questions. If I didn't get to your question, please feel free to send me an email to webinars@rogersbh.org. Many thanks to our presenters for taking the time away from their clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask our presenters to share a few key take-home messages from today's presentation.
Just briefly here, I hope that you were able to hear that comorbid conditions, they can interfere with treatment of one or the other, regardless of which one you start with, and that we really need to try to ascertain whether or not someone meets criteria for diagnosis of both. But I'll say too, if someone just has clinically severe symptoms, even if they don't meet the full criteria, we need to take into some extra considerations how we're going to address it. And that there are some really, really good treatments out there. And I strongly recommend using the gold standard treatments as identified by the scientific community and by APA. There's 3 to choose from for PTSD and one main one for OCD. So we can't integrate these. That's probably another webinar that we can talk about that, but there is a way to try to blend these things together.
Thank you. That about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after this webinar ends, you'll receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint presentation, slide handouts, and a complete list of references. Those of you who met the time requirement for the CE credits will just need to complete the evaluation and download your CE certificate for the event. If you have any questions about this follow-up email, please contact support@ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support our patients. Thank you.